the majority of patients to, perhaps the majority of patients to reach target doses in clinical trials. Many patients don't reach target doses, at least. So how does that work? So here we have spironolactone. The target, according to the guidelines, is 50 milligrams per day. But my a la carte menu says that I would like a potassium of round about 4.5. I don't need to go much higher than that. I don't need to go much lower. It sort of really tells me that that I've got target physiological engagement, and I think that that's important. Occasionally I'll go higher, but 4.5 is I feel very comfortable with that. So if we have a patient with a potassium of 3.7 on 50 milligrams of spironolactone, the guidelines tell you not to change, but on the a la carte menu, we're licensed to go up to 400 milligrams of spironolactone, and many clinical trials of heart failure have gone to 100 milligrams of spironolactone. So I'd certainly consider a higher dose depending on the blood pressure and renal function. On the other hand, a patient with a potassium of 4.9 on 25 milligrams of spironolactone, the guidelines tell me to increase to 50 milligrams per day. I would feel uncomfortable with that. 4.9 is a good potassium, unless there's another compelling reason to increase the dose of spironolactone. I'd be very happy with 25 milligrams. You can do the same with beta blockers. Carvedilol, the target dose is 25 milligrams BD in the guidelines, but my a la carte choice would be to achieve a heart rate of around about 60 beats per minute in a patient with HFrEF, that is. So a patient with a heart rate of 75 beats per minute on 25 milligrams BD of carvedilol, guidelines say no change, but I would push on to 50 milligrams twice daily. Likewise, if we've got somebody with a heart rate of 62 on 12.5 twice daily, the guidelines would tell me to increase to 25 milligrams BD. They only tell you to stop when the heart rate's below 50 beats per minute. On the other hand, I would feel quite comfortable with just leaving them there at 12.5 twice daily. Sacubitril valsartan, of course, we're now talking about hemodynamic guidance, the blood pressure and possibly the vascular resistance, and we have much less certainty about what we'd do here. And with vericiguat, pretty borderline result in the clinical trial, but I've got, I feel it's a patient with a high vascular resistance who was doing poorly. This is certainly a drug that I would consider trying under those circumstances. So should hemodynamics guide treatment? This is the sort of thing the NICAS can do for you. It gives you a nice set of information, set of hemodynamic information that tells you where the patient's sitting. So here we've got a patient in NYHA class 3 with an ejection fraction of 32%, currently receiving pretty decent therapy, perhaps not optimal. You can see that they've got a low cardiac output and a high peripheral resistance. So perhaps we need to do a little bit more for this patient. And the obvious thing to do for this patient would be to switch their ACE to an ARNI, which we did. And as you can see with that, the cardiac output did come up a little bit and the vascular resistance came down. But certainly this patient's still not ideal. So you might say, well, what else could we do for this patient? And this is a sort of patient where if they're still struggling, you might consider further vasodilation and or might even consider digoxin, try and get their cardiac output up. You might feel that there are other hemodynamic patients. But of course, the also shows you that the QRS is quite broad in this patient, so perhaps they would be a candidate for CRT. And there has been a little bit of information on the use of the NICAS device for optimizing CRT. Some people think it's maybe even useful for selecting patients for CRT, but personally I would use the QRS duration On the other hand, having implanted a CRT device, we know that optimizing hemodynamics can be quite tricky. And there is evidence that with the NICAS device that you can improve the hemodynamics, and hopefully that improved hemodynamics will then translate into better long-term outcomes with the CRT device. We don't have any big randomized trials of the NICAS device. There are some small ones, and I'll tell you about one in just a moment. But these are there's considerable observational data, which is really quite intriguing in terms of hospital, the community management of heart failure. You can see that there are some before, after, and some cohort-controlled clinical trials that have gone on, and they show that with the information that you get from NICAS, it seems to improve outcome. Now, whether that's because you have a better choice of therapy, whether it's because you just achieve the guideline recommended targets better because you have more engaged patients and more engaged staff, or whether the patients actually want to know their numbers. My experience is that they do want to know their numbers, and then in order to achieve their numbers, they know they have to take the medication. For hypertension, there's been a very large implementation study done in hypertension with evidence of much better control of hypertension in patients who where treatment is guided. And I think very much the same sort of idea that perhaps this is a better choice of treatment, but also patients being more engaged and therefore more likely to take their medication. There's also evidence for better management of gestational hypertension, and also intriguingly for neonatal monitoring, that in premature babies, they have a higher risk of cerebral bleeds, and a lot of that seems to be related to problems with hemodynamic management in these babies. And there's some evidence that the NICAS device might be very useful in terms of trying to prevent those terrible cerebral bleeds, which can be fatal or leave a child injured for the rest of its life. So here is a randomized controlled trial. This is acute hemodynamic monitoring of a new drug, Simlenod, for congested heart failure. It was a putative inodilator, so it was meant to both cause vasodilation and have an inotropic effect. You can see with the power index that there was no change in the power index, indicating that, at least by this hemodynamic measure, no evidence of an inotropic effect. There was a big reduction in the total peripheral resistance, TPR, and associated with a rise in cardiac index. So that sort of sounds good. We've offloaded the heart, we've improved cardiac output, we've reduced peripheral vascular resistance, but notice the increase in body water and the reduction in hemoglobin, indicating that there's been plasma volume expansion as a result of this powerful vasodilator. And you can see that because of excessive reductions in systemic vascular resistance, we've seen a fall in urine volume in red with Simlenod compared to blue, which is placebo. And likewise with the urine sodium, lower with the Simlenod than the placebo. So the hemodynamics has really helped us to understand what's going on here, and indicated that this drug might improve acutely your hemodynamics, but you need to be very careful that you're not actually causing salt and water retention. Bioimpedance can not just be used for the management of heart failure, but also potentially for diagnosis. This is the Granov-Gur index, and we can maybe discuss with the experts on the panel exactly how that's derived. But this index is basically of contractility, so it's potentially an inexpensive and user-friendly way of getting an estimate of left ventricular ejection fraction, which you can see plotted on the graph here. So if you wanted to screen a population quickly, easily in your cardiovascular risk clinic, this might be a very good tool to weed out those with ventricular dysfunction. Professor Jakobshvili with us today, and he can tell us a little bit about his experience with cardio-oncology use. As I've said, I'm very interested in the use of this technology to detect myocardial dysfunction caused by chemotherapy or radiotherapy, so that we can alter either the dose of the chemotherapy or to get in early with management of the cardiac dysfunction for these patients. So this is the relationship to the marker NT-proBNP. So in conclusion, I think NICAS puts the technology for measuring hemodynamics in our hands so that we can help tailor treatment to individual patient needs. This, for me, begins to address the precision medicine agenda of the right patient, the right medicine, the right time, and the right dose. And I think it should also encourage and sustain optimal care for many patients across many disciplines. So thank you very much for listening, and I'll hand you back to Igor Granov, who will take you to the next speaker. Thank you.
Professor Cleland, thank you very much. It was very